without further ado, I am very pleased to introduce Jess Lincoln. Jess, please go ahead and take it away.
All right. Yeah. Thank you everyone for joining us today. Yep. I'm Jess Lincoln. I'm an account manager here at ACI 340B Management. I am also joined by my CEO, Adam Grad. And before I get started, I would like to offer the floor to Adam to help lay out a little bit more about what we're talking about today. So Adam, take it away.
Thanks, Jess. Thanks for your time today and this incredible turnout. ACI is a national 340B management / consulting firm based in Boise, Idaho. Our sole focus is 340B. ACI is frustrated by the move to a rebate model. We understand pharma's desire to eliminate commercial rebates, but not at the expense of struggling hospitals and clinics. There are better alternatives. 340B hospitals and clinics expand their reach and services into the community. And the rebate model will limit this by creating a complex system that places the financial burden on the hospital. Pharma is trying to make the program so complex that CEs, hospitals, clinics, quit the program, making the juice not worth the squeeze. They've been doing this for at least 8 years in various ways, like restricting contract pharmacies. ACI is a vendor-neutral 340B management firm, which means we work with all the TPAs in the 340B space. Even though we're not there while working towards it, none of them have systems in place to deal with the rebate claim submission, let alone the payment verification. I have confidence that they will get there, though. The rebate model will put additional strain and complexity on the rural hospitals' already stretched resources and additional workload on the staff that have little enough time to care for their patients. Our goal is to help navigate this new hurdle as smoothly as possible. Jess is going to give a nice overview of the rebate program, but really it comes down to individual questions. And there's a great Q&A section afterwards. And don't hesitate, if you have additional questions afterwards, to reach out individually. With that, turn it back over to Jess.
All right. All right. Thanks, Adam. Yep, like Adam said, I would like to talk about HRSA's new 340B pilot rebate program. This might be a refresher for some of you. Some of you may have joined seeking more information. But this presentation will cover what we know up to this point about the rebate model, but it is subject to change, just like anything in 340B. So with that, let's get started. So the purpose of the pilot rebate program is to give drug companies an avenue to provide 340B discounts in the form of rebates instead of upfront price reduction. This will allow manufacturers to evaluate claims and even to evaluate claims before granting 340B discount. It's no secret that drug manufacturers don't like 340B, and so they've long been pushing OPA to change the 340B system to a rebate model. So this pilot is a way of appeasing them and giving them more control. Currently, the model will only apply to a select set of drugs, but in HRSA's proposal, they did allude to potentially expanding this model. So it's also unclear which covered entity types will be subject to this rebate model, but manufacturers did have the option to apply their rebate proposals to all covered entity types. So given that flexibility, it's likely the rebate model will impact all covered entities. But this pilot also offers OPA the option to evaluate the merits and shortcomings of a rebate model before potentially expanding it. So we can't stress enough how important it is for your voices to be heard in opposition of this rebate model. ACI is offering our suggested verbiage for comments to HRSA if you're unsure what to say. We would also highly recommend contacting your state representatives. ACI also has some suggested verbiage for you as well when doing that. So this is the initial scope of drugs that were selected to be a part of the pilot rebate program. These 10 drugs also make up the selected drugs for the Medicare Drug Price Negotiation Program, also known as the MDP&P for 2026. HRSA only included these MDP&P drugs in this pilot to create a more structured and limited scope to test this post-purchase rebate model. OPA may announce a call for rebate plans from other manufacturers with MDP&P agreements later as well. So I'll take a pause for you all to review those drugs there. All right, we're gonna keep it moving. These are just some of the general requirements that manufacturers had to meet when submitting their proposals to HRSA. So manufacturers must cover all IT platform and admin costs. So covered entities won't be charged for using the rebate system. And in the future, if any new manufacturers would like to join the rebate model, they must give covered entities 60 days notice before starting that rebate model. Covered entities will also be able to continue using their current TPAs and wholesaler accounts. They'll be able to order these rebate drugs through their existing 340B account. This just means that the WAC price will be loaded into your 340B account for those selected rebate drugs. So there's no need to create a separate WAC account for these drugs at this time. And then manufacturers also must provide technical assistance and customer support. Covered entities will have access to both the IT platform contacts and a direct manufacturer contact. So this is just a high-level look at the timeline so far. So manufacturers submitted their plans on September 15th, and then OPA will approve these plans by October 15th. And then the rebate model is going to go live on January 1st, 2026. Between now and this January 1st start date, OPA is looking for comments and feedback from covered entities. So again, I can't stress enough how important it is for you to get your comments into HRSA. Now, this is just a high-level look at of how the rebate process is going to work. So covered entities will buy these drugs at WAC, and then you'll have 45 days from the dispense date to submit your claim data. Right now, it's unclear which platform will be used for these data submissions, but it seems very likely that they'll be using Beacon. Beacon is a site that was going to be used in past proposed rebate models, so it's very likely that they will go with this site. The claim data fields for these claim submissions will be made up of very similar, if not the same, information that's already required for ESP data submissions. And then once that those data submissions are in, manufacturers must pay the rebate within 10 days. And then this rebate being the difference between the WAC price and the 340B ceiling price. And OPA has committed to ensuring manufacturers pay this on time, and they will also be closely monitoring the provided reasons for any rebate denials. So I'd like to discuss, visually what these rebates are going to look like. Now, this is how the 340B process works currently. I'm going to use a $100 prescription as an example. Now, I think we're all familiar with the 340B process, so I'm just going to go over this very quickly. Hospital sends their encounter data to a TPA. The TPA then collects a copy of the switch data being transmitted to the insurance companies. The TPA then orders the 340B drugs and sends a purchase order to the wholesaler. The wholesaler then replenishes the pharmacy. The TPA then invoices the pharmacy and then sends the remaining revenue to the covered entity, taking out any dispense fee and TPA admin fee. So whatever remaining revenue then gets sent to the covered entity. And then the wholesaler sends a invoice to the hospital for the drugs that were purchased on 340B. So this is generally what the 340B process looks like currently. This is what it now looks like with these rebate model claims. I would say the key differences here is you'll notice that the wholesaler invoice is now $80. this is now the WAC price instead of that discounted 340B price. There's also the rebate claim data submission arrow, and then you'll see the rebate arrow from Beacon up to the hospital that makes up that $40 in revenue that you get for that 340B drug. Now, if the diagram was hard to follow, I've broken it down just financially right here. On the left is the current cost flow for 340B drugs. You'll notice this is the total collected by the pharmacy. These are your total fees, your ingredient cost, the pharmacy dispense fee, the TPA admin fee. So if we take 100 minus 60, your 340B revenue is $40. That's how it stands normally. Now with the rebate cost flow, pharmacy still collects $100, but now your ingredient cost isn't discounted. It's now that WAC price, which is $80. So then your total fees come out to 100 minus 100, you get 0. And in some cases, your total fees actually might be above what the pharmacy collected, and you might be upside down on that claim. So once you get your data submitted, the rebate from Beacon will come in the form of $40, whatever that difference is between the WAC and the 340B price. So if for whatever reason that claim does get denied, you're going to be out that $40 in savings and potentially even upside down on that claim when you may not have been before. So this is a little more information about the data submissions themselves. Like Adam said, TPAs are not currently ready to support this rebate program. Again, like Adam said, we've spoken with many of the large TPAs and they don't expect to have anything ready until at least November. But this ready date could continue to get pushed closer to that January 1st start date or even after. From past experience, we know how they handled ESP data submissions. Some offer downloadable claim reports, some still don't. Some have an automated data submissions and others don't. So it's really important that you know how to submit these claims yourselves. And so this next slide, I'd like to go over roughly how you would pull these claims yourselves to submit to Beacon. So you're just going to pull a regular audit file of all of your qualified claims. You're going to isolate these rebate claims by matching up the rebate NDCs to the claim NDCs. And then you're going to format these rebate claims to the required data submission file format. You're going to submit this file to Beacon. In Beacon, they claim that you'll be able to track the rebate at the claim level. So in Beacon, you'll track these rebates, then you'll track and make sure that Beacon sends that rebate. You'll then follow up with your account receivables team to make sure that those invoices and rebates from Beacon were received. We do believe that this is the most important part and potentially the hardest part of this rebate model is tracking the money, tracking the financials, making sure that you are receiving those rebates and you're not upside down on those claims. So this is a little more information about the rebates. Rebates can't be denied over diversion or Medicaid duplicate discount concerns. If manufacturers have concerns about diversion or duplicate discounts, they can take up their concerns with OPA either through audits or dispute it through other channels. Covered entities will also have the ability to report any rebate delays or denials to OPA. Any denials made by the manufacturers must include a clear reason and documentation. And these denials could include it's a duplicate claim, this claim has already been submitted by another covered entity, things like that. And then, like I said before, the rebate model will be paid at the claim level. Previously, with other proposed rebate models, the rebate would be paid after the claims fully accumulated to a package. But this has been amended. It will be at the claim level. So yeah, HRSA is looking for feedback on this rebate model. So again, it's very important that covered entities like yourselves continue to speak out about this model. And again, if you're unsure how to draft your comments to HRSA, ACI is willing to share our drafted comment for covered entities. These are maybe just some of the high-level questions and concerns you may be having, and ACI's comment does cover all of these concerns. These are just some of the implications for covered entities. This will drastically change your drug acquisition and cost flow. Covered entities will now have to pay that higher WAC price up front and then receive rebates later, rather than getting that 340B discount at purchase. Again, this will change how 340B revenue is tracked, and this will unfortunately be a burden on your account receivables team. This will also pose some administrative burdens in the form of those data submissions. You will need to track these rebate claims and submit data within 45 days of dispense using a new IT platform, which can add additional reporting responsibilities for someone on your team. But this does open the door for new opportunities to give feedback to HRSA. So again, we encourage you to submit your comments and call your representatives to oppose this rebate model. These are just some of the next steps that I would recommend you all start taking. I would continue to look for any HRSA updates and track 340B news. If you're not already subscribed, I would recommend the 340B report. But if you're looking for a more cost-effective option, you can visit ACI's website for additional articles and newsletters. I would also prepare your systems for this rebate model. Who's going to be doing your data submissions? How are you going to track these rebates? You need to start thinking about these systems. Now, it's not the ideal route, but you can choose to carve these drugs out of your program if you don't feel it's worth your time and energy to track them. I would just recommend conducting an impact report on the potential loss in program revenue if you were to choose to carve these drugs out. It's something that we've already discussed and conducted with our covered entities, and we feel ready to help them participate in the rebate program. And then again, submit your comments and contact your state representatives. Your comments can be posted on regulations.gov. I do believe comments are currently closed, but they will open again, and that's going to be your main point of contact to get your comments in to HRSA. All right, so with that, I would like to open the floor to any questions.
Okay, I have not seen any questions come in yet, but this is a great time to submit them. We have the chat function at the bottom of the screen. We have, again, the Q&A option available to you. Or if anybody would like to raise their hand, you can do that, and we will unmute your line. We'll allow you to ask your question verbally. So does anybody have any questions they'd like to submit? We do have a question in the chat now. How can you submit claims within the 45 days, making sure that you don't send duplicates?
A great question. I think of these data submissions very similarly to the ESP data submissions that we currently do. So when you are grabbing your claims, you want to be sure that you're not overlapping in your time frame that you're grabbing, but then also you can track them by not submitting again that same time frame. You can also pay attention to the date of service, the RX number, things like that. We would recommend that you do your data submissions on a weekly basis. If you're the one that has to manually pull them on a weekly basis. Again, only doing that time frame a week at a time. That's really my best answer for that. Adam, do you have anything to add there?
No, you have far more experience doing that than I do, so you're the expert there.
Okay, we do have another question. At the end of this trial period, do you think that CAUSE will be impacted by this model?
My opinion is that they're going to expand it out over all of the covered entity types. It is the dish facilities that really cause the issue within 340B, and unfortunately, critical access is wrapped up into that. Our predominant client base is critical access, so I am a little skewed towards that. You know, I'm trying to protect rural healthcare. And I think the changes need to be made more in the dish section. A lot of hospital associations that I've worked with across the country don't like that because they're supported by the dish facilities. But critical access will be wrapped up along with FQHCs, STDs. So that's my humble opinion.
Thank you.
I do see a follow-up from Mary on the how to submit those claims without submitting duplicates. I guess if it is recommended by your TPA to overlap that date range, there should be some sort of number to identify unique claims, whether it's like a claim number, your MRN number. There's a number of, it just depends on what TPA and how they label it, but there is typically a unique number that identifies each individual claim. Without knowing the TPA and being familiar with that audit file, I couldn't tell you exactly what it would be, but there should be another number that identifies it.
Okay. I am not seeing any other questions come in. A ton of good information in there. So thank you very much, Jess and Adam, for joining us today. Anybody that has any other questions, I know can reach out to you at the contact information you've provided there on the screen. But we do appreciate everybody's time today, and we'll go ahead and let you get back to the workday.
Thank you,
Thank you all very
everybody.
much.